he has chest pain. He's 51 years old. This is obviously not the same patient you're seeing on this slide here. And he has multiple risk factors. He is hypertensive, he is diabetic, and he has very high lipids. So a risk constellation, obviously, which would point to coronary artery disease. But let's first see what you think of this patient. I'm not going to tell you what his ECG and what the other lab parameters were, but just take a look at these images and look for yourself and try to find out which information you can draw from these images. This is the parasternal long axis view. The aortic valve. Take a look at the septum, the left atrium. This is another parasternal short axis view, this time with color. See if you can estimate the severity of valve lesions. Now this is a short axis view. Let me just adjust this a bit so you can see it a bit better. You should hopefully see these images quite nicely on your screen. Okay, this is a short axis view somewhere at the level of the papillary muscle. Good. This is another short axis view. While you're at it, also look at the thickness of the septum. This is the aortic valve. Here you would estimate if the valve opens or not. Here's an M mode across the aortic valve. Remember, this is the box that opens during systole. This is the left atrium, the right ventricular outflow tract, and the ascending aorta. See if you can see anything abnormal here. Now let's turn to the apical views, the 4-chamber view. Now keep in mind, the patient presented with chest pain. So this was his initial presentation. And in the back of your mind now, try to make up your thoughts, what it could be, and which potential differential diagnoses you would expect in such a patient. Look at the heart chambers, especially the left ventricle, of course, left ventricular function, and particularly of regional wall motion. Now this is mitral regurgitation. Another look at the aortic valve, showing the aortic valve and regurgitation here. Tricuspid valve with regurgitation. Okay. Another 4-chamber view. An apical long axis view. I'll give you some time because I really want to have you to closely look at the wall motion of these patients that I'm going to show you, because this is one of the most difficult things there is in echocardiography, to determine if patients have abnormalities of regional wall motion, and then secondly, what kind of regional wall motion abnormalities are present. Okay. Inferior wall, remember this is the 2-chamber view. We see the anterior wall here and the inferior wall here. Okay, and this is another 2-chamber view. Sometimes I record more than one 2-chamber view, or views in general, because you might see one portion of the myocardium better in one view opposed to another. So that's why I usually record as many as possible. Okay, so now coming back to my question, what do you think this patient actually has? And I want to show you again a poll, or ask you a question and see if you can give me the correct answer. Okay. What do you think is the problem here? Does the patient have just simply hypertensive crisis? That's why he has chest pain and dyspnea? Does he have, actually they should read hypertrophic cardiomyopathy. That would be the second possibility. Do you see an inferior myocardial infarction, or you see an anterior myocardial infarction, or an amyloidosis? Okay, only 5 have voted yet, 9, 11, 18%. Okay, so you're coming along here quite nicely. Yeah. So even if you don't know what it is, at least make an educated guess, because that does, at least put you in the driving seat. And I will then show you, of course, the correct answer. Okay, still a few more to go. Okay, I'll close the poll now. And the results are, okay, 33% think it's hypertensive cardiomyopathy, 25% hypertrophic cardiomyopathy, 25% think it's an inferior myocardial infarction, and 31% think it's an anterior myocardial infarction. And a few think it's just simply a hypertensive crisis, and nobody thinks it's amyloidosis. Okay, so let me solve this case for you and go through the case once more, but now with a bit more explanations. Let's start with the parasternal long axis view. Okay, so first thing you really should appreciate immediately is that the patient has massive left ventricular hypertrophy. I'll just show you how you can quantify that very simply just by doing a measurement on the 2D image. I'll try to find an end diastolic frame, which is somewhere here. And then I just use the caliper and measure somewhere from here to here. Now this is 18 millimeters, which is very much. 18 millimeters is certainly a distance that is far beyond the 11 millimeters that someone should have. Now I even get 20 millimeters. So even though this is just a rough estimate, it clearly shows that there is left ventricular hypertrophy. Now the next thing I'm going to show you is the same thing in a two-chamber view. And here in the two-chamber view, what you probably will appreciate quite nicely is that aside from the fact that the patient has concentric hypertrophy, in other words, all the parts of the myocardium are thickened, we also see that there is a reduction in left ventricular function. Function does not appear to be normal. The question now will be, is this globally reduced left ventricular function, or is it regionally reduced left ventricular function? In other words, do some parts of the myocardium pump better than others? This is not an ideal short axis view. The reason is that the patient was not so easy to image, and the left ventricle looks more like an egg than a circle. But even though it might not be possible to put an M mode through here and measure the distances with M mode, it is still okay to look at regional wall motion abnormalities. And if I would look at the septum here, I would have the impression that the septum does not move as good as the posterolateral wall. Remember, if we look at the different segments of the myocardium, this here would be the septum, this would be the anterior wall, this would be the posterolateral wall, this would be the inferior wall, and this would be the inferior part of the septum. So if you look at this region here, my impression would be that the wall motion is not really normal. But keep in mind, what you're seeing here is only one slice of the heart. This is only one short axis view, so it tells you nothing about the apex because we're not at the apex. To see the apex, we have to look at other parts of the myocardium as well. And you can see these very nicely with an apical four-chamber view. And the first thing that I always do is, if I have a four-chamber view, I ask myself, now is this a good four-chamber view? Do we have foreshortening? Do we really see the apical portions of the myocardium? And you can tell if you have an apex which is not too round and more like a dome. Which this actually is. I think this is not really entirely at the apex, but it's fairly okay because we have a left ventricle which is fairly long. So we are seeing the apical segments. Okay, now let's go back again to the question regional or global function and just compare the different segments. Look at the wall motion here at the basolateral wall and compare it with the wall motion, for example, here. You will immediately see that this is almost hyperdynamic opposed to this portion here. The septum does not pump the way it should either. So I would say there is a regional wall motion abnormality right here at the apex. Aside from these findings, other things that I just want to point your attention to is we have a very large left atrium. We also have normal right ventricular function, and then there is a very small pericardial effusion here. Do you see this? Right here, lateral. Okay. By the way, if you have any questions, just post these questions to the chat window. I'll be glad to answer them along as we go along. So please just raise your hand and post the questions. By the way, do you actually all see the videos quite nicely? If anybody does not see the videos nicely, well, if he's the only one that does not see the videos nicely, then he probably has some form of connection problem or computer problem. But let me know if any of you do not see the videos nicely, because this is most important. So to assess the entire left ventricle, we need, aside from the 4-chamber view, also an apical long axis view. And this is an apical long axis view showing you something very similar. We have differences in the way the myocardium contracts. This part contracts very nicely at the basal part of the posterolateral wall. And this seems to be okay as well, but the problem seems to be here in the septum. You see this? This is the septum that is not pumped normally. And now back to the 2-chamber view, which shows us the anterior wall here and the inferior wall. And again, we have the anterior wall much less contractile than the inferior wall. So in summary, what I would say to this patient is, what I would say to these images, that the patient has a wall motion abnormality in the apical segments and the anterior segments. Now, what does the patient have? Well, he had an acute anterior myocardial infarction. Of course, he also has left ventricular hypertrophy caused by severe arterial hypertension. The patient had blood pressure values all over the place between 180 to 110, even above that, and even came in with very high blood pressures. So he was brought to the cath lab, and what we found was that he had an LAD occlusion, and the vessel was reopened, and everything was fine. But the main point I would like to make here is that you really have to look at these wall motion abnormalities very closely to be able to find such wall motion abnormalities and compare the segments with each other. This is very important.